and a good evening to one and all. I welcome you all for today's webinar on Revolutionizing Oncology Pathways to the Progress. It is the second day where we are going to discuss GI and prostate cancer. And with immense pleasure, I would like to invite Dr. Tarachand Gupta, who is consultant medical oncology at Bhagwan Mahavir Cancer Hospital and Research Center. And also, with a warm welcome, I would like to invite Dr. Asim Samar, who is consultant medical oncology at Bhagwan Mahavir Cancer Hospital and Research Center for the opening remarks. Over to you, sir.
Thank you, Team Horizon, and thanks to Dr. Tarachan for inviting me. And I'm sure this will be the wonderful conference, and it is about the progress in the GI oncology and the prostate cancer field. And these two cancers are known to be commonest in the men. Obviously, the prostate cancer is the topmost cancer, and the GI cancers are also common and increasing. And so we need updated our knowledge time to time. And in last 1 year and maybe 1 year or so, the progress in both the fields are immense. And you see, immuno-oncological drugs are coming in a big way in the GI cancers, maybe in the neoadjuvant setting, adjuvant and metastatic setting. So it will be helpful to review all the new articles and new paradigm shift. And in prostate cancer, we know somewhere we are going for the HRD testings and having some good molecule as a PARP inhibitors, and few molecular progress has been happened. And you see, the if you do the genomic testings, so more or more we are doing the testings and we are getting the results. And now we are able to target the particular mutations and pathways also. So this is all about the how we go about the testings and target the pathways and give some OS or some PFS benefit better than before to our patients. And obviously, the having the good knowledge about the recent progresses and the uh, recent knowledge, it will just deliver to the patient's care and safety. So time to time update is essential, and this is the one step in this particular agenda. And Dr. Tarachand has made this progress, and I'm sure yesterday's conference was wonderful. And today's I saw the list of the speakers, and they are very well arranged and balanced. And few moderations and moderators are very wonderful. So I'm sure we will be having good academic feast. And both these common cancers are requiring maybe twice in a year knowledge update, and he has taken the step forward. So I am very much sure he will do the good job, and all the speakers will be doing their job very wonderfully done. And from Dr. Tarachand's side, I would request all the speakers to be in time. And sorry, I am in between the travel, so I will not take much time. And already we are overshooting the time. So 3-4 minutes I have taken more time. So over to you, organizers, to please invite the next speaker. And uh, best of luck to all the organizers and Dr. Tarachan. Over to you, Team Horizon.
Thank you, sir. Thank you for such a gratitude remarks. And as we proceed, our first session is sponsored by our academic partner, MedGenome. And for this, I would like to invite Dr. Suruchi Agarwal from Bangalore. And she's going to deliver her talk on prostate cancer biomarkers, clinical implications. Over to you, ma'am.
Sure, thank you. I will share my screen. Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay.
Yes, ma'am.
Okay, thank you so much. Is my screen visible?
Yes, ma'am. Yes, it is visible, ma'am. You can go ahead.
Okay, okay. Thank you so much. So good evening, everyone. And thank you, Dr. Asim, for setting the context and introducing the topics. So basically, today I'll be speaking on prostate cancer biomarkers and clinical implications. As we all know, since the emergence of precision medicine, the genomic profiling of the cancer has become indispensable, and it gives us a lot of information regarding the tumor biology and how to clinically manage the tumor based on the biomarkers that we detect through genomic profiling. In prostate cancer specifically, metastatic prostate cancers, the genomic profiles are more complex as compared to the early cancer types, which we will be seeing in further slides. So if we look at the, is my slide moving? Yeah. So if we look at the this particular slide shows some summarized treatment of advanced prostate cancer. So the treatment of advanced prostate cancer will depend on whether it is a hormone sensitive prostate cancer or it has developed into a castration resistant prostate cancer, and that too whether it is non-metastatic or metastatic. In advanced settings, usually the molecular profiling is preferred because of predictive biomarkers that are available. And as you can see here in the call out, there are certain predictive biomarkers like HRR deficiency, which confers eligibility to PARP inhibitors, or MMR deficiency seen in 4 MMR DNA damage response genes, or MSI phenotype or tumor mutation burden, which becomes high, that confers susceptibility to immunotherapies, and PTEN loss for AKT1 inhibitors. And then there are certain tumor agnostic biomarkers like BRAF, RET, and NTRK fusions, which can be used in prostate cancer as well. And we also get to know information about germline predisposition. And this particular figure shows the molecular landscape of prostate cancer across TCGA cohort. And here you can see more complex genotypes that we can see as ERG fusions in 46% of patients was seen, or ETV1 fusions and overexpression, ETV4 fusions and overexpressions, FLE1 fusions. And then there is a category SPOP mutation, which is related to favorable prognosis, longer response, and it co-occur with certain mutations, and then it shows favorable prognosis if this is present. Then FOXA1 mutations, IDH1 mutations in about 1% prostate cancer patients, and others like TP53, KDM6A, MYC, and CCND1 amplification. However, if we look at the predictive biomarkers, so same HRR, which confers HRD phenotype or DNA damage response genes. They are about 18% in localized prostate cancer and 25% in metastatic prostate cancer, and they confers eligibility to PARP inhibitors. Then CDK12 minus phenotype, which is 2% in localized and 5% in metastatic, and DMMR or MSI phenotype, which is more in metastatic settings. So these are predictive biomarkers here in TCGA group. Also, they have shown the percentages which differ between localized and metastatic. So how to profile them or how to do genomic profiling? So basically, it can be a genome-wide assay or it can be panel-based assay, and it can be done on tissue biopsy wherever tissue biopsy is possible, prostate biopsy or a metastatic tumor biopsy, or it can be done on liquid biopsy sample as well, which is plasma cfDNA or CTCs. CTCs is not in the guidelines right now, but plasma cfDNA for mutation analysis is in the guidelines and has gained importance over a period of time. Then based on these assays, we have clinical outcomes prognostically, like whether poor or better, or we have actionable alterations like we discussed. And these are some of the actionable predictive biomarkers that we usually would like to see in the patient so that a particular therapy or a clinical management can be planned accordingly. And you can see most of the actionable biomarkers, they are in metastatic settings. And there are different FDA-approved therapies for these biomarkers. Interestingly, BRCA mutated patients, they are more likely to develop metastatic disease. And here there is a data of around 2,000 patients where BRCA1 or BRCA2 mutated carrier 23% of them showed a metastatic disease, but non-carrier, only 7% of them showed metastatic disease. And here also you can see the stage 4 disease is present in 28% of non-carrier as compared to BRCA2 carriers. So BRCA mutated patients, they are more likely to develop metastatic disease. Now, coming on to the technical side to understand how we can test these biomarkers. So we have a test that is done on tissue tumor testing or on archival FFP blocks, which has high clinical sensitivity and it is gold standard as per guidelines. So it is archival tissue, always available. We can test it. However, the quality matters. It is localized from a particular site, so it can miss some spatial and temporal tumor genetic heterogeneity. And sometimes the sample to obtain the sample, it is difficult because the metastatic site may be a bony lesion or the site may not be accessible. So sometimes it is challenging to obtain the sample. And even if we obtain the sample, initial histopathology or immunohistochemistry will deplete the tissue, or we may not have enough tissue to proceed with. Sometimes the archival blocks, they are old, and therefore we are not able to get the good quality of DNA or RNA so as to perform NGS testing. So tissue has been an issue that we know, and there are 30% of patients as per PROFOUND trial where tissue testing could not yield results. So there, the importance of ctDNA testing comes, where it is easy to obtain testing samples because it is minimally invasive, and it confers, or it does not have this genetic heterogeneity because it will capture the DNA from all the metastatic sites as well as primary site. But one limitation is that we have to sequence at higher depth, and high sensitive tests are required, which now NGS has developed, and we have optimized assays for ctDNA mutation testing. It may result in sometimes false negatives or false positives. So it is very important to understand why the result is negative sometimes on ctDNA testing. It may be due to the low amount of cfDNA in the blood that is shed from the tumor. Therefore, the negative result has to be taken with a pinch of salt, and we have to actually do the tumor testing, if it is possible, rebiopsy, to confirm whether it is a true negative or not, because it can be due to low amount of ctDNA in the blood. Then we have germline testing. Germline testing will give us only germline variant when we do the test on the whole blood. However, tumor and tissue testing gives us both germline and somatic variants, because tissue will also have germline DNA, germline variants, and plasma ctDNA is basically shed from the tissue only. So that will also have germline variants. So it can detect both germline and somatic. However, we cannot distinguish whether the variants, for example, if we got a BRCA2 variant on tissue and plasma, we cannot make out from the result that whether it is a germline or it is a somatic. So that in that case, we have to confirm it on the blood of the patient to confirm whether it is a germline variant or not. VAF will give us a fair idea, like whether it could be germline or not. If the VAF is above 30%, it is usually suspected that it could be germline, and therefore it is important to confirm it on the blood of the patient. But when we do the test only on blood, we will only get germline variants, and we may miss 50% of those which are of somatic origin. So this data actually shows that BRCA2 is the most common HRR gene that is found mutated in the prostate cancer patients, followed by ATM, CDK12, and other genes. And if we are doing a germline mutation only, then or testing on the blood only, we may miss 50% of patients. So this particular figure shows the same thing, that tumor or liquid biopsy based approach identifies all patients with HRR gene mutations. So our testing algorithm becomes like, we have a tissue sample for HRR testing. We prefer doing somatic testing first. Test is performed. If it is negative, conventional therapy. If it is positive, then we have PARP therapy. And if it is positive, then we have to confirm whether it is germline or not. And if it is germline is positive, then familial screening and prevention strategies should be administered for family members. And if it is negative, then conventional therapy. If somatic testing is not performed or it doesn't yield any result, then we go for germline testing for HRR genes so that at least that 50% of patients could be identified. Coming to comprehensive genomic profiling, which includes all actionable genes, tumor agnostic genes, HRR genes, then other immunotherapy biomarkers like MSI, TMB. So this particular data is on around 3,476 prostate cancer patients, which showed DNA damage repair genes were mutated frequently, PI3K pathway was mutated, RAS, RAF, MEK was mutated. TP53 percentage was 43.5. It is shown in this graph as well, followed by P10, AR, MYC, BRCA2, RB1, APC, and other genes to name. Then TMP, RSS2, ERG fusion was found in 31.2% of prostate cancer patients, and other fusions like ETS or BRAF or RAF1 fusions were also reported through comprehensive genomic profiling. So basically, comprehensive genomic profiling will give the complete picture of genomic profile of the tumor, and clinical management decisions can be taken accordingly. These are some of the fusions that we have reported through RNA sequencing in our samples which are tested at MedGenome. So TMP RSS2 ERG fusion we report very commonly, which is associated with poor prognosis in prostate cancer patients and confers more aggressive prostate cancer phenotype. And these are some of the rare fusions that we have identified. Then ETV1 and ERG fusions also we have identified in our code, just a glimpse of some fusions. And as we know, MSI and TMB, both markers, they are important in advanced prostate cancer, which shows response to immunotherapy. And if MMR genes are mutated, then Lynch syndrome can be suspected. Now, coming on to the importance of liquid biopsy in genomic profiling of prostate cancer patients. So this particular slide shows the profound trial data where 4,047 patients were tested for tissue, and you can see 31% of the tissue were failed. And why they were failed? They were failed at pathology review or DNA extraction level or after DNA extraction level. About 1,255 tissues were failed, and out of that, most of them were core needle biopsies, and if it was prostatectomy, the higher success rates were observed. And some samples were from bone, which is not recommended for next generation sequencing. And other samples, they were archived more than 3 years or more than 2 years, and only 10% were newly collected tissue. So these are some of the reasons why tissue fails. And at our center also, we have identified that amount of tissue left in the FFP block, that is very important. Like, what is the volume of the tissue left in FFP block? Then what is the tumor content evaluated by a pathologist? If the tissue is there, whether it has tumor cells or not, it should be at least, ideally, it should be 20% and above. More ideal, it should be 30%, but in our Indian samples, we hardly get samples which are 30% or above, or major, the failures that happen is below 10% or between 10 to 20% tumor content. So this is again a very important criteria. At our lab, we will reject the samples which are below 10% tumor content. And if it is a bony component, fixation artifacts or autolysis, and if age of the block is greater than 3 years, DNA extraction quantity and quality. So if we run the samples on tape station and we see the profiles, if the profiles are flat, that means the DNA is completely fragmented, and therefore the samples are rejected. And these are some of the QC checks that are being done on all tumor samples which reaches lab. So volume of the tissue, sufficient tumor content, then DNA quality, concentration and yield, and then library QC after the probes are hybridized, and then NGS data QC for coverage and depth. So at these levels, the rejection may happen and tissue may not yield enough results. So in PROFOUND trial, they showed that tumor testing as well as ctDNA testing, the concordance was about 92% in 315 samples. So this shows that, okay, liquid biopsy can be used as a reliable alternative when tissue biopsy is not available. And this is the data from MedGenome, where we have tested 86 patients, out of which 66 were paired tumor biopsy and 20 were only liquid biopsy. As you can see, in paired, we observed a concordance of 95.1%. And where only liquid biopsy was available, tumor biopsy was not available, therefore patients showed tier 1 variant. So here lies the importance that liquid biopsy can be considered as a safe and a reliable alternative when tissue biopsy is not possible. And same is recommended in the guidelines also, that if the biopsy is unsafe or unfeasible or it is not done, then ctDNA assay is an option. So now we can actually look at the algorithm. Sorry. So now we can look at the testing algorithm again, that we can see if the tissue is available for testing.
I would request to conclude your presentation.
Yeah, sure. So consider ctDNA testing using liquid biopsy and germline using liquid biopsy. So these are some of the tests which are available at MedGenome for all of the biomarkers that we discussed. And I would like to discuss just one case study before concluding. This was comprehensive genomic profiling done on a prostate cancer patient, 72-year-old male. TMB was low, MSI was stable, and PALB2 loss of function variant was identified. Germline HRR panel was also done, and it was positive. So it was a positive PALB2 on germline as well as tumor. Brother was tested PALB2 positive. Son was tested by NGS, and we got PALB2 as well as BRCA2 pathogenic, because there was a positive history on index's wife side as well. So son got, I think, PALB2 from father, and we suspected that BRCA2 is coming from mother's side. Maternal side family members are being screened, and daughter is also getting screened. So this is a somatic HRR report, and this is germline HRR report. And this is another case where TMP-RSS2 ERG fusion was identified. Thank you so much.
Thanks, Dr. Suruchi, for insightful knowledge about the driver mutations and other genomic alterations in the prostate cancer. Now I invite Dr. Ajay Singh from Tata Memorial Hospital, Mumbai, for the talk on neoadjuvant approaches to the high-risk prostate cancer. Ajay, please.
Thank you, sir, for the introduction, and thank you, organizing committee, for giving the opportunity. I'll just share my screen, sir. Is it visible?
Yes, sir.
Okay. Again, good evening, everyone, and thank you, Tarakan sir, for invitation. So today we will be discussing the role of neoadjuvant in high-risk prostate cancer. So coming to the background, as we are aware, prostate cancer is a very heterogeneous disease, and as far as therapeutic point of view, we divide this prostate cancer into three parts: localized disease, locally advanced disease, and metastatic. Again, the localized, the organ confined disease is again substratified on different this low risk or intermediate risk or high risk based on the PSA level, that is D amicus criteria, which includes PSA level, then this cancer tumor grade or Gleason score, and the last is the T stage, and there are some other risk stratification factors like Capra system and nomograms. So again, coming to this risk stratification, so we are specifically focusing on the high risk group, which includes PSA more than 20 nanograms, the Gleason score is more than 7, or clinical T 2C stage, or other part is the locally advanced. So this includes either clinical T3 or T4 stage, or those involving pelvic node involvement. So these two where we consider neoadjuvant neoadjuvant therapy. So again, majority, you can see that almost 80% cases are generally organ confined, and they have 5-year survival rate above 90%, up to 99% as well. There are only 15% cases which are generally have locally advanced disease, and their 5-year survival rate is around 60 to 80%. And last, only 5% patient present upfront as a metastatic disease, and their 5-year survival rate is around 30 to 40%. So you can see that as the stage of the disease increases, again the survival becomes poor. So this is in general the therapeutic guideline for localized prostate cancer. So you can see that in low risk and some low intermediate risk, there are three options: active surveillance, radiotherapy, and radical prostatectomy, based on the patient's preference and life surveillance. We need to discuss all the options and high intermediate risk or high risk. Then local therapy is more important, and in that also either radiotherapy or radical prostatectomy, we add additional phase of androgen depression therapy along with radiation for 2 to 5 years, or we add pelvic lymph node dissection with radical prostatectomy. So where is the role of this neoadjuvant therapy in prostate cancer? So again there is a basic principle for this, as in other cancer site like tumor shrinkage, to make the resection feasible and deliver the RT easily, to control the micrometastatic disease, and to improve the oncological outcome like survival and disease free survival. And last, depending upon the response to therapy, will give some disease biology information which will help in prognosticate the disease. So what is the need of neoadjuvant therapy in prostate cancer? We so biochemical recurrence rate is around 30 to 50% in this localized high risk cases at 10 years. Then positive surgery, if their margins remain positive after surgery, then the chances of this biochemical recurrence increases. So to improve this outcome, like uh, prolong the biochemical recurrence, and in margin positive cases to decrease the need of RT or other therapy, these few new adjuvant therapy has been proposed in prostate cancer. The first one is androgen depression therapy, then chemo hormonal therapy, then last is the novel hormonal along with the ADT. So coming to the each data, so for first androgen depression therapy, there are some retrospective data which are published in 90s till 2000. So you can see that in that this acute outcome like the clinical downstaging on pathological downstaging and margin positivity were favor the androgen depression therapy, but there was no any data on the long term outcome like overall survival or disease free survival or metastatic free survival. So but in this androgen depression therapy retrospective data, they have shown that these acute outcomes like downstaging of the disease on margin positivity rate, seminal vessel invasion rate, and nodal involvement were had shown favorable response to the androgen depression therapy as a neoadjuvant approach. But in randomized study, you can see that the long-term outcome like disease-free survival or biochemical-free recurrence and overall survival was not significantly improved with the help of androgen depression therapy. So overall conclusion with the androgen depression therapy as a neoadjuvant is that it made the short-term goals like increasing the clinical or pathological response, decreasing the margin positivity, decreasing the nodal involvement, but long-term outcome like chemical recurrence was not improved. Coming to the next option like chemo hormonal data. So here again, there's a very limited data. There were two studies which were recently published few years back in 2019 as a retrospective study, and only there was one study in 2009 which was reported, which was a randomized trial. So in retrospective data, you can see that this chemo hormone has shown trend toward improvement of all oncological outcome like including overall survival, uh, with the chemo. So in the randomized study, you can see that at 10 years, the overall survival was marginally improved from 74% to 80% in the chemo hormonal group. So coming to one randomized data, so which by the CalGB group, it was a phase 3 study included 788 patients. Again, they randomized patient in the new hormonal chemotherapy group followed by surgery against upfront surgery, and they have shown that they have lower the acute outcome like the pathological T stage were in favor of chemo hormonal therapy. Then there was margin positive was and nodal involvement was decreased, and the seminal vessel invasion all were decreased, and it favored the new hormonal chemotherapy approach. But they also reported the longer outcome in 2019. They have shown the 8-year biochemical progression-free survival was significantly improved with the new chemo therapy. That again in the same year they have presented the 10-year overall survival rate, and again they have shown that with the new chemo
Sir,
therapy.
request you to
The
conclude your presentation in 1 minute.
okay.
Thank you.
So again, for chemo therapy, there is a limited data, but it has shown both the short and long-term improvement in the survival. And again, but there is no still more prominent data, but it needs more consolidated evidence to prove the role of chemo therapy as a neoadjuvant. Then last is the novel hormonal therapy. Again, there are not much data, but there are few trials, and again they have shown that it helps in downstaging and control the biochemical recurrence and metastatic free survival. So these are this intense androgen depression therapy along that includes androgen, abiraterone, apalutamide, and androgen depression therapy. And here again they have met their acute outcome like improving of the patch CR rates and minimal residual disease. And again, at longer follow-up, they have shown that 3-year biochemical PFS was also well controlled with the this intense novel hormonal therapy. So, coming to the conclusion, for novel hormonal therapy, again, there was no difference in pathology complete or minimal residual, either you go abiraterone with ADT or abiraterone apalutamide with ADT. The pathology complete response was more in patients who achieved this PSMA PET as a CR. So this PSMA PET was a surrogate marker for the pathological CR and minimal residual disease. So take home message, at present there is no recommendation regarding the neoadjuvant therapy in prostate cancer. In selected patients with high risk localized disease can consider 6 months of ADT along with chemo or novel chemo ADT combination. At present, whatever data is available, benefit in short term outcome is there. For strong recommendation, we need more well designed study. With this, I like to thank you again for the giving the opportunity.
Thank you, sir. Thank you for such a lucid talk. Next, I would like to invite Dr. Tarachan Gupta for his talk on new targets and agents in upper GI cancer. Over to you, sir.
Thank you, madam. This talk was delivered to me by Dr. Divesh Raval. He is not well, so I'm presenting on behalf of him. So please run my slides, please. So we are discussing today the new target and agents in upper GI cancers. So upper GI, that means gastroesophageal cancers. So this is the disclosure slides. And now there are multiple targets are available now in all over oncology, and especially gastric and esophageal cancer we have seen nowadays. Those are the IHC or fish-related NGS if we do the HER2 positive, and other are the IHC PCR and NGS method. We can do MSIH, DMR, and PDL1 expression. This is by the IHC, NTRK, and other the biomarker unselected therapies. These are the ramucirumab, third line, nivolumab, apatinib also. For HER2 positive cancer, we are having the along with chemotherapy, trastuzumab and TDXD also. For MSI high, we have the pembrolizumab and dostarlimab and PDL1 expression. If there is more than 5%, then we can add nivolumab with the chemotherapy. And for NTRK, those are the agnostic. This is the agnostic marker, which is entrectinib or larotrectinib. So these are the line, and we now new are coming up. Those are FGFR, EGFR, MAT, EBB, cyclin D1, MSSR, TMB high. So please next slide. So biomarker personalized therapy, this was the Victory trial in which the patients were enrolled for the Victory screen, 56.4% at the time of first line of chemotherapy and 43% during the at the time of failure to the first line chemotherapy. Patients were enrolled, and tumor pathognomic genomic profiling was done. That was targeted tumor sequencing, nanostring MAC signature, IHC panel for MMR EBV status, PDL1 CMET, and the fourth arm was the serial circulating DNA sequencing. So in arm 1, there was salumetinib, docetaxel, KRAS mutation or amplification. The arm 2 were the advoserib, paclitaxel, TP53 mutation. Arm 3, it was capivasertib, paclitaxel, PIK3C mutation or amplification. Arm 4, that was savolitinib, MET amplification. Arm 4 savolitinib plus docetaxel. Arm 5 savolitinib plus docetaxel for the MET3 by ISC. And Arm 9 was vistirib plus paclitaxel, and Arm 10 was bisphosphonates plus paclitaxel. Next. So in this trial, we can see that if we are treating the patients with the conventional chemotherapy or in a conventional pattern, and versus the patient with that biomarker-driven treatment, then we got the good survival probability, and with the better progression-free survival than the conventional chemotherapy over the time. That was 266 patients were in conventional chemotherapy arm, and 105 patients were in biomarker. Next slide, please. In this trial, arm 4, there was a savolitinib for patients with amplified gastric cancer were seen, and this is the for waterfall plot. We can see there was more survival chances if the patients are targeted with the savolitinib rather than conventional chemotherapy. Next. So this is the gastric cancer, which is known for the heterogeneity of the expression of gene profiling, and even in the trastuzumab, there is heterogeneous expression of HER2 over the gastric cancer. There is intratumoral and concurrent gene alteration. We can see this is the primary, which is shaded by blue, and in HER2, where there are metastatic lesion, it is a red shadow. We can see clearly difference when the it was metastatic setting. Then it is HER2 loss, and HER2 targeted therapy can be given that can cause the HER2 loss, and HER2 targeted therapy, and there are acquired genomic alterations are there. Next. We have discussed this intratumor heterogeneity from the variant study. Next. And thus, with survival with trastuzumab, as we can see, there is a clear-cut difference between if the patients are treated with the HER2 positive, HER2 targeted therapy along with the chemotherapy, there is clear-cut difference in the survival rate, and it improves the overall survival also. Next. HER2 heterogeneity and survival with trastuzumab. Yeah, we can discuss in the last slide. Next slide, please. Novel HER2-directed therapies, trastuzumab deruxtecan. This is the newer drug which has been newly launched, and I think we are waiting in India also. There is in this humanized HER2 IgG1 monoclonal antibody with same amino acid sequence as trastuzumab. There was tetrapeptide-based cleaver linkage, and topoisomerase 1 inhibitor work as the payload. Next. In this, we can see that whenever we target with this drug, there is an antibody HER2 binding is there. Then ADC internalization that causes a linker cleavage and payload release, and that payload is the topoisomerase 1 inhibitor that target the cell nucleus and membrane payload to the release from cell and enters the neighboring cells. And this can cause the bystander effect also. So this is the R2, and the payload is around 8. Next. So this was the Destiny Gastric 01 trial in which the HER2 positive tumors were targeted with TDXD, and that show the response with the physician choice. It was 14%, and with the TDXD it was 51% response. Next, please. And the median overall survival was there was 12.5 months with the TDXD and physician choice. It was 8.4 months with a hazard ratio in favor of TDXD, the 41% reduction of death. Next, please. The most troublesome effect or side effect of the TDXD is, as with the newer drugs we see nowadays, it is the interstitial lung disease. That is the all grade of in cancer clinical trial. It is 7 to 9.6%. That is the worrisome effect. Next. So this is the ongoing study. That was the next, please. Ongoing study. In which this is the FGFR2 beta receptors are targeted with the target drugs. Next. FGFR2 directed antibody bemarituzumab was designed to recruit the tumor-killing NK cells into the tumor microenvironment, in which the enhance the ADCC to the increased NK cells recruitment that leads the venom and bemarituzumab antibody specific to the FGFR2 splice variant, and that causes the cleavage linkage and the release of the bemarituzumab into tumor cells, and there is less bystander effect. Next. This is the FIGHT study. Now there are good names of the studies, easy to remember. Key eligibility criteria: there is no prior therapy for unresectable locally advanced or metastatic gastric or gastroesophageal junction cancer. With the RECIST available criteria, FGFR2 beta overexpression and FGFR2 gene amplification, no HER2 positive. So these are excluding all the other mutations. Stratified the geographic region, single dose of FOLFOX while screening have received or not, and prior perioperative chemotherapy. So if patients are randomized, bemarituzumab plus modified FOLFOX6 versus placebo plus modified FOLFOX6. Primary endpoint is PFS and secondary endpoint is overall survival and response rate. Treatment may continue until the progression, unacceptable toxicity, or the patient meets other withdrawal criteria. Next. Eligibility included FGFR2 beta by IHC positive or circulating tumor DNA positive. 30% of the 910 pre-screened patients were eligible with the overexpression of IHC plus positive, and there are FGFR2 IHC positive defined as 2 plus or 3 plus screening, and the FGFR amplification threshold of 1.5 fold increased by the gene amplification method. Next. Most enrolled patients had tumor FGFR2 beta overexpression without evidence of FGFR2 amplification. The circulating tumor DNA total was 16.8%, 12.9% were IHC positive, and 3.9% were IHC negative and circulating tumor DNA positive. So this was the status of GFR2, status of enrolled patients. Next. The higher the FGFR2 beta presentation and the higher the efficacy of bemarituzumab, the overall PFS was 9.5 versus 7.4 month with the in the experimental arm. While if the patients are having IHC 2 plus or 3 plus with the 5% or more amplification, it was bemarituzumab 10.2 versus 7.3, and if it expression increases, then the response increases to 14.1 versus 7.3. Same with the overall survival. When the overall survival not reached in the bemarituzumab arm versus placebo, it was 12.9. For the lower expression, it was again in the placebo arm, it was 12.5, and in more amplification arm, it was 11.1 month. Overall response rate. So FEL, next please. Evaluation of efficacy by biomarker status. So this is the forest plot. We can see that the FGFR2 beta expression, IHC positive patients are having more response with the bemarituzumab, and circulating tumor DNA positive also. If the patients are having both positivity, then the chances are high in PFS and OS both sides. So next.
So I would request you to conclude your presentation 1 minute.
Median overall survival reached with a longer follow-up of addition of bemarituzumab showed a 5.7 month improvement in median overall survival. Next. Next. These are the coronal side effects. Next, please. We have discussed this. So this is the multi-tyrosine kinase inhibitors. Any role of inhibiting FGFR and other kinases. This is the integrate 2B trial and a randomized phase 3 open label study of regorafenib plus nivolumab versus standard chemotherapy in refractory advanced gastroesophageal cancer. Another study is LEAP-015 and LEAP-05. This LEAP-015 is the phase 3 study evaluating the efficacy and safety of first-line pembro plus lenvatinib, and LEAP-05 is evaluating lenvatinib plus pembrolizumab in patients with previously treated selected solid tumor. Results from gastric cohort study. Next. Claudin 8.2. This is also a novel target that we can see in the future very soon. Next. This was the first randomized phase 2 trial in which the EOX plus minus Zolbetuximab was compared along with the placebo control arm, where the biomarker selected patients were having better overall survival than the conventional chemotherapy. Next. So next, please.
So I would request you to conclude your presentation 1
Yes.
minute.
So, ma'am, please, next, please. These are the upcoming that are ongoing study. These are CAR T cell therapy can be discussed in HEMAT also. Please, next. These are the full of pipeline tumor, the targeted markers. This is the upregulated tyrosine kinase as therapeutic target, spatial and temporal heterogeneity, HER2-directed therapies, FGFR2, multi-tyrosine kinase inhibitor, Claudin 18.2, and bispecific antibodies. Next. Thank you for the patience listening.
Thank you, sir. Thank you so much for your such a lucid talk. Next, I would like to invite Dr. Jagdeep Singh from Ludhiana, and he's going to speak on targeting the HER2 pathway in upper GI cancer. Over to you, sir.
Thank you, Ekta, and thanks, Dr. Tarachand. So, my job is to give a lecture on targeting the HER2 therapy pathway in the upper GI. So I'm sharing my screen. Just let me know. So, is it visible?
Yes, sir.
Yes, sir. Make it full screen, please.
Yes, just one second. So, can you let me know whether it is moving also?
Yes, sir.
Thank you so much. And thanks to the team for organizing this event. So my job is to just one second. Targeting the HER2 pathway in upper GI cancers. So I just listened to what Dr. Tarachan said about the latest drugs in the upper GI cancers and addressing the TDX and other therapies like bemarituzumab. So a lot of drugs are in the pipeline. Maybe we will be having a new data. So which is the better to choose in that? So these all pancreatic biliary tract, esophageal gastric cancer, these all have a very high morbidity and mortality despite lot of advancements. But it was a few years back, it was only limited to the chemotherapy. But nowadays we have a lot of target therapies for, and of course the NGS is the talk of town everywhere and it's revealing new targetable pathways. So there are 4 genomic subtypes from the US Cancer Genome Atlas that is genomically unstable, and they have the basically tyrosine kinase amplification in the form of HER2 or FGFR. Could be MSI high, where could the immune checkpoint inhibitors can be used, and genomically stable. There is no such target available for those, and EB virus, and for this could be some sort of sensitivity to the immune checkpoint inhibitors. So HER2, this esophageal gastric cancer is just one thing. Is not same as the breast cancer. A lot of therapies are there for the chemotherapy, but in the case of a target therapy, there were a lot of trials, but they could not succeed, and ultimately finally this trastuzumab in the TOCA trial was one which got the approval. Similarly, with the Avastin, they have tried a trial, but it did not show any survival benefit. So Avastin does not come into the patient picture. Though the other receptor blockade, the VEGF, that is ramucirumab, is there in the second line, but the bevacizumab does not hold good for the patient with the gastric cancer. So this was a first line approved in combination with the capsis, and it showed improved response rate and progression-free survival as well as the overall survival. And this was up to a tone of 13.8 months versus 11.1 months with a hazard ratio of 0.74. So another combination is with the capox along with the lapatinib, but it did not show any difference in the OS patient with the addition of lapatinib. And again, pertuzumab failed to show the overall survival benefit when it was combined with the trastuzumab and cisplatin in patients. So this TOGA trial was a phase 3 randomized international multicentral trial, and approximately close to 580 patients who were HER2 positive with advanced gastric cancer, they were randomized either to capsis or 5FU plus cis and placebo or trastuzumab. So this is the regimen which was used in the trial. So not going to detail for that. So if you see in this overall survival, the patient who received this trastuzumab along with the chemotherapy backbone, the overall survival, median overall survival was 16 months as compared to 11.8 months in the patient who was receiving the chemotherapy. So it substantially improved the OS in patient with having the higher expression of HER2 protein, either 2+ or FISH positivity, or patient having ISC 3+, as compared to the patient who are having the low expression of this HER2. And it clearly demonstrated the patient who received this trastuzumab along with the chemotherapy bone, they did a pretty better, and with a hazard ratio of 0.635, that approximately 35% of the patient has has a less chance, 35% less chance of the patient who are having death as compared to the patient who are receiving chemotherapy. So this trial concluded that in combination with the chemotherapy trastuzumab, this adds benefit to the OS without affecting the overall safety profile in the patient with the metastatic GI cancers. And this was a new standard of option for a patient with a HER2 positive advanced gastric or GE junction cancer when combined with a chemotherapy resistant regimen that is either capsis or 5-FU plus cisplatin. So another drug to the basket was the dual anti-HER2 therapy, that's trastuzumab plus pertuzumab. Now it did not showed any survival benefit in the Jacob trial, but there was some another anecdotal studies or some phase 2 studies which showed that there is some benefit in not only gastric but maybe in other the biliary tract cancer. So if you see in this, the patient the biliary tract metastatic cancer who express the HER2 positivity, this trastuzumab plus pertuzumab plus along with the chemotherapy, they did some better in the patient who were exposed to this. So approximately the patient who had some partial response or stable disease as compared to the patient who did not have any change from the baseline. So maybe this could be one combination in that is only just phase 2 in the biliary tract cancer, but not in the gastric. Another combination is of the pembrolizumab along with the trastuzumab plus chemotherapy in the HER2 metastatic gastric and its GE junctions. And this was basically a phase 3 study which showed that a patient who received this combination did better, who had expression of PD-L1 more than 5% in the patient with the metastatic or advanced gastric or esophageal gastric disease. So the primary endpoint of this study was overall survival and the PFS, and the secondary endpoints of overall response rate and the duration of response. So if you see in this interim analysis, the patients, the overall response rate was close to 74% as compared to 51% in the patient who were receiving this placebo. And again, the overall disease control rate, and that is again better with the patient who receiving this pembrolizumab as compared to the placebo. And among the best responses, the patient who received this pembrolizumab with the trastuzumab with the chemotherapy, the complete response or partial response was much on the higher side as compared to the patient who received the placebo. But if you see the stable disease, that is more on the side of the patient with the placebo with the trastuzumab and chemotherapy. And if you go with the duration of response, median was approximately 10.6 months in the pembro arm and 9.5 months in the placebo arm. So this showed that the overall response was pretty better with the patient who were receiving the pembro along with the trastuzumab and the chemotherapy combination with a good complete and partial responses. So this was a list of the FDA-approved indication of the checkpoint inhibitors in the advanced GE junction cancers. So you can see that the patient who can having either PD-L1 CPS score more than 1 in the advanced or metastatic settings, and the patient who means with some progressive disease on or after 2 previous therapies, they can be one of the next candidates for the patient who can receive this immunotherapies. And other was the patient with a HER2 positive gastric cancer, again in the first line setting, trastuzumab along with the platinum based along with the 5-FU based. This is the standard of care as the first line. And again in the esophageal with the squamous cell histology with the CPS more than 10, and patient, you can see the patient can be a candidate for the immune therapy. And similarly with the tumors who express this tumor MMR deficient who are having a high mutational burden, again immunotherapy can be one of the options. So this was talking what we were about the first line. In the second line, again there are a lot of drugs, and it was seen that TDM did not do a better as compared to taxanes. Again, the phase 2 combination of trastuzumab into the second line, that is either with the paclitaxel, there was no difference in the PFS or the OS benefit. So why? Because there is de novo acquired HER2 resistance likely, so that's why there could be a loss of the HER2 expression that may occur in the patient with the gastric cancer when we expose this patient to the second line anti-HER2 therapy. Other drugs into our basket, Dr. Tarajan just briefed about the Druxtecan. This again, that is a ADC, and it has shown approximately 43% response rate in the initial trials. And now the Destiny phase 2 trial versus chemotherapy, that is a gastric 01. And that trial has again showed some benefit. And this approval for the adult patient with the locally advanced or metastatic HER2 positive gastric or GE junction patient who had received prior the trastuzumab-based regimen. Next line is the margetuximab, and again the phase 1 or 2 trials that shown the response rate of approximately 18% along with the pembrolizumab, and the phase 3 trial, that is Mahagoni trial, is going on. And next line is a zendetamab, which is again targeting HER2 or HER3 receptors. So Drextecan, not going to detail because Dr. Tarjan just briefed about the DAC, that is high, the DAC, sorry, DR, that the ratio is high, so we have a better effect. And of course, this tumor is a selective, having a selectable cleaver linkage and high bystanding killing effect. This all makes these drugs a very potent drug for the patient who are having a HER2 positive in the second line, and one of the bases which can make a patient have some sort of a response who are exposed to this drug. This is a Destiny Gastric 01 trial in which a TDX, the patient who previously treated HER2 positive gastric or GE junction. This is a phase 2 randomized study, and if you see the patient were exposed to a TDX or either physician's choice of irinotecan paclitaxel, and this was given until a progressive disease or any unacceptable adverse events, and the primary endpoint was the overall response rate. So patient who received the TDX, the overall response rate is marginally high as compared to the patient who received this either irinotecan or cisplatin-based therapy or paclitaxel-based. And again, the confirmed overall response is either in the form of PR or CR. They are much higher as compared to the patient who are receiving the physician choice of drug. And again, disease control was pretty high with the patient who are having exposure to TDX as compared to the physician choice of drug. And the median duration of response is markedly high in these with the patient with the exposed to the TDX. So if you see these all results from the overall response rate to the confirmed overall response rate and disease control rate and median duration of response, this initial phase 2 study that has clearly shown a benefit patient who are receiving the TDX as compared to the physician's choice of chemotherapy. So this is a graph showing the Destiny Gastric 01. You can see the overall survival in the patient who are exposed to the TDX is 12.5 months versus 8.4 months in the patient with a physician choice of treatment with a hazard ratio of 0.59. And the PFS was 5.6 months with the TDX as compared to 3.5 months with the patient who are exposed to physician choice. So both PFS and OS that showed a statistically significant benefit were exposed to this TDX as compared to the physician choice of treatment. So another drug is margetuximab. This is a HER2 targeted chimeric monoclonal antibodies, and it enhanced the ADCC toxicity versus trastuzumab, and it's a single agent activity of margetuximab in HER2 positive has shown a confirmed response, partial response rate of approximately 10%. So combination of different immunotherapies with the anti-HER2 therapies in the form of either the trastuzumab or in the combination of the margetuximab, it has shown some benefit on the patient who are receiving this drug. And if you see the best change from the baseline from the target lesion is more in those patients who are having a gastric cancer and who are exposed to this combination after a first line of previous treatment with a trastuzumab-based chemotherapy. So just in continuity with this patient who showed either HER2 positivity or amplification or with PD-L1 positive tend to do better as compared to patients who are either HER2 negative amplified or PD-L negative. So the yellow graph, these are all the patients which both show the HER2 amplification as well as the PD-L1 positivity. So this is margetuximab in combination with the chemotherapy for previously untreated HER2 gastric or G junction. This was a phase 2/3 trial, and if you see the patient who receiving this therapy, sorry, so
I
I'm
would
not sure
request
about
you to
the.
conclude your presentation in 1 minute.
So this next drug is again a targeted bispecific antibody, that's zanidatamab. So basically it's a biparatopic binding agents. It binds on two different HER2 epitopes, the same antigen, and thereby producing its enhanced HER2 receptor clustering and leading to internalization and increased biperiodic tumor cell binding density and leading to the cytotoxicity. So it's a very well tolerated in the preclinical studies. So this is just a phase 1 study which has shown some objective response rate in the patient who have received. So approximately some close to 40 to 50% of the patient has shown some response rate with this. So this is again a phase 1 study. So these are the new therapies in the patient with the gastric or esophageal gastric cancer who are having some HER2 expression. And of course, trastuzumab in the form of TOGA trial and TDX in the second line. They are the approved therapies. And these are the some of the recent therapies in the form of zenditamab or margetuximab, and phase 1 and phase 2 study has shown some updates in the management of first-line biliary tract cancer. Next slide. So biliary tract cancer includes gallbladder cancer, cholangiocarcinoma, extra and intrahepatic. So coming to the statistics, India is one of the hub for biliary tract and gallbladder cancer, especially in females, with the highest rates in the Ganges belt in the eastern part of the country and like Assam, Eastern UP and Delhi. And unfortunately, 90% of these patients, they are diagnosed at a later stage where the disease has gone beyond the surgical option. And with whatever standard that we have, that is the common, that is gemcitabine and cisplatin, the median OS is less than 1 year and 5-year OS rate is less than 10%. And there has been an increase in the trend for the incidence of biliary tract cancer in both the females and males over the next years. Next slide. So I'll be discussing what new has come up in the current management in advanced biliary tract cancer. So this was the study is ABC02, where gemcitabine plus cisplatin was established as the standard first-line chemotherapy for biliary tract cancer. So it showed a PFS benefit of 8 months as compared to 5 months, and the OS benefit was around 11.7 months versus 8.1 months. So GemCis continues to remain the standard of care, with very newer therapies that has shown to provide a better outcome as compared to GemCis. Even now with the availability of durvalumab, still GemCis remains a category 1 indication as per the NCCN guidelines. Next slide. So few of the patients, we see that they are not fit for cisplatin. So we have a chemotherapy backbone to offer to them, that is combination of gemcitabine and oxaliplatin doublet. So this was a TMH study which showed that GemOx as compared to GemCis results in similar response rate, EFS and overall survival. It has some advantage that it lowers the cost of the treatment with decrease in the incidence of peripheral neuropathy, hepatotoxicity, and there is lower incidence of hematological toxicity, and it can be given in those patients who are elderly, who are borderline fit because of some renal or cardiac functions. Next slide. So you can see that in the 2022 guidelines, GemCis is the preferred treatment option. And on the basis of NGS, if you find any actionable mutation in subsequent lines, targeted therapy can be offered. Like we do get sometimes IDH, NTRK, RET mutation. And if it is MSI high, then pembrolizumab can be offered. Next slide. Next slide. So we have now something new that we can offer to our patients, and we can at least something has come up after around 20 years of treatment of gallbladder cancer, and that is immunotherapy. Next slide. So this is the study which on the basis of which durvalumab was approved in the first line treatment. It's called the Topaz-1 trial. It is a phase 3 randomized double-blind placebo-controlled study of durvalumab in combination with GemCis in patients with advanced biliary tract cancer. Next slide. So the inclusion criteria of this study was locally advanced or metastatic biliary tract cancer with recurrence more than 6 months after curative surgery or last dose of adjuvant therapy, and the patients were relatively fit. They were randomized in 1:1 with durvalumab maintenance, durvalumab plus chemotherapy followed by durvalumab maintenance, and the standard arm was GemCis plus placebo. They were stratified on the basis of disease status versus the location of the tumor. Primary endpoint was overall survival. Key secondary endpoint was PFS and overall response rate and duration of response. Next slide. So coming to the baseline characteristics of the two arms, durvalumab plus GemCis plus and the second arm placebo plus GemCis. Median age was around 64.
50% patients were of Asia and 50% from rest of the world. Majority of the patients were intrahepatic cholangiocarcinoma, around 55%. Extrahepatic cholangiocarcinoma were around 20%, and gallbladder cancer were around 25%. And most of the patients had initially unresectable disease, that is de novo metastatic disease, around 80%, and 20% had a recurrent disease. Next slide. In terms of MSI status was missing in majority of the patients. Around 50% of the patients' MSI status was not known, and it was high in less than 1% of the patients. Few patients had viral etiology also. Viral hepatitis B was present in around 20% of the patients. Hepatitis C was present in around 2.3% of the patients. Next slide. So ongoing treatment was present in the durvalumab plus gemcitabine arm. At the time of analysis, around 18.6% had an ongoing treatment. In the placebo arm plus gemcitabine, around 5.8% had ongoing treatment. Treatment discontinuation was present in 81% in durvalumab plus gemcitabine and 94% in placebo plus gemcitabine, and the major reason was disease progression. Subsequent anti-cancer therapies were given in 42% in durvalumab plus gemcitabine, and the majority of that treatment was cytotoxic chemo. And in placebo plus gemcitabine, around 50% patients, they were able to receive second-line treatment, and the most common was the cytotoxic chemotherapy in 45%. Next slide. Coming to the curves, the Kaplan-Meier curve, Imfinzi, that is durvalumab plus gemcitabine, is the first and the only approved IO which has shown a 2-year sustained and durable OS benefit when it's combined with gemcitabine. The median OS was 12.9 months as compared to 11.3 months. The hazard ratio was 0.6. At 1 year, the OS was 54 versus 47%. At 18 months, it was 34 versus 24%. And at 2 years, it was almost double, 23.6 versus 11.5%. Next slide. Coming to the subgroup benefit, you can see that almost all these subgroups had a benefit of durvalumab plus gemcitabine combination. Whether the patient was less than 65, more than 65, PD-L1 expression did not has any implications on the benefit of adding durvalumab, and baseline metastatic disease or recurrent disease both had benefit, and the benefit was more in extrahepatic cholangiocarcinoma, and the benefit was slightly less in those patients who had gallbladder cancer. Next slide. And this combination also demonstrated a statistically significant and superior PFS against gemcitabine. It was 7.2 months versus 5.7 months. 6-month PFS was 58.3 versus 47.2%, and 12-month was 16% versus 6.6%. Next slide. And again, the PFS benefit was seen across all the subgroup. The benefit was more in the extrahepatic cholangio group, and according to the site, it was less in those patients who had a GB primary. Next slide. In terms of response rate also, 1 in 4 patients remaining in response, they continue to respond beyond 1 year also. The overall response rate was 24.6% in the combination arm versus 18.7% in gemcitabine. Next. And those patients who had continued response after 1 year, it was 26.1% in durvalumab plus gemcitabine and 15% in placebo plus gemcitabine. The disease control rate was 85% in durva plus gemcitabine, and in gemcitabine plus placebo, it was 82%. The median duration of response in months was 6.4 months in durva plus gemcitabine, and in placebo plus gemcitabine, it was 6.2%. Next slide. So basically, those patients who had initial response to durvalumab, and if that response was stable disease and was maintained at 6 months, there was a sustained separation curves at approximately 6 months. So that means that after 6 months, these patients usually continue to derive the benefit of adding durvalumab. there was a clear and sustained separation of the curves beginning approximately 15 months after randomization. And among participants with the best response of stable disease, that was sustained separation between the curves at approximately 6 months. Next slide. Coming to the adverse events, any serious adverse events occurred in 99.4% of the patients versus 98.8%. Respectively, any grade 3-4 adverse events in the Durva plus Gemcis was present in 75.7%, and 13% patients had to discontinue the treatment because of adverse events. And in terms of immune-mediated adverse events, 2.4% of the patients had grade 3-4 immune-mediated adverse events in the Durva plus Gemcis arm. Next slide. And as expected, that most of the adverse events were because of the chemo counterpart of this combination. You can see that the adverse events between the Durva plus Gemcis versus placebo plus Gemcis, they are almost similar. So this implies that probably majority of the grade 3-4 adverse events, they were because of the chemo counterpart and not because of durvalumab. So anemia was present in around grade 3-4 anemia was present in 23% of the patients, neutropenia around 20%, and decreased platelet count around 10%. Other side effects were GI side effects and increase in the liver enzyme. So they were similar in both the arms. Next slide. So coming to the safety and toxicity of adding durvalumab to chemo. So as discussed, most of the grade 3 and 4 adverse events, they were hematological and they were comparable between the two arms, implying that chemotherapy was the reason of these side effects, that is decreased neutrophil count, neutropenia, anemia, decreased platelet count. Next slide. And in terms of immune-mediated adverse events, only less than 2.5% patients had grade 3 or more immune-mediated adverse events. The significance of this were dermatitis in 0.9%, pneumonitis in 0.3%, and incidence of hepatic events in 0.6% of the patients. So majority of the immune-mediated adverse events, they were grade 1 and 2, and they were manageable. And immune-mediated adverse events did not lead to an increase in the number of patients discontinuing study treatment. So as discussed, the number of patients discontinuing treatment, they were similar in both the treatment arms. Next slide. And the OS for durvalumab versus placebo for participants with or without an immune-mediated adverse event. So what this slide is trying to show, that even if the patient had immune-mediated adverse events, that did not have an impact on the overall survival of the patient. The overall survival benefit was present irrespective whether the immune-mediated adverse events happened or not, whether there was requirement of stopping the immunotherapy drug had an impact on OS. The OS was 17.3 months in durvalumab plus Gemcis in patients who had immune-mediated adverse events versus 14 months, and those patients who did not have had a median OS of 12.6 versus 11.4 months. Next slide. So now you can see that there has been a change in the NCCN guidelines in the IO era, and apart from the standard gemcitabine cisplatin, it also recommends addition of durvalumab as a category 1 indication, and it is the only immunotherapy molecule that has been approved irrespective of the PD-L1 status in metastatic and unresectable biliary tract cancer. Next slide. So it's definitely a new era in the biliary tract cancer management, although we do expect to find some more breakthroughs in this malignancy because it's a difficult disease to treat. And as discussed, although there is definitely a benefit that is seen with durvalumab, but in terms of numerical benefit, it's not very well anticipated. So we do expect something new actually comes up apart from durvalumab that we can offer to our patient. Next slide. So to conclude that, durvalumab plus Gemcis demonstrated a statistically and numerically significant benefit. It was clinically meaningful as compared to placebo plus Gemcis. And with regards to the biomarker status, biomarker need not be done before offering durvalumab in combination with Gemcis in biliary tract cancer patients. And in terms of safety, durvalumab did not add any additional toxicity to that seen with chemotherapy. There were no new signals. And it is also DGCI approved 1500 milligram in combination with chemotherapy. And Topaz is the first global phase 3 trial to report positive results with immunotherapy and chemo combination as first line biliary tract cancer. Next slide. So thank you all for your patient listening. Thank you, Dr. Tarachan.
Thank you, Rajit, for a nice talk. Now I invite Dr. Jitendra Pelajani for the next talk on
So Dr.
KRAS
Jitendra has not joined yet. I think he's stuck somewhere. So, Dr. Tarachan sir, can we start with the panel discussion?
Then I think Jitendra will join in after that.
So, can we start with the panel discussion?
Yes, we can start, I think, because I think he got stuck because just before he called and then he was fine. I am trying to connect with him. So we will take a call later on.
Yes, sir.
So I invite Dr. Rishabh Kothari from Ahmedabad. He is a co-founder of Rishabh Kani, sorry. I invite Dr. Ankur Punia for the case-based panel discussion on metastatic colorectal cancer. His panelists are Dr. Yashwant Kashyap, Rakesh Sharma, Rajit Charana, Jitendra Pelajani, and Rohit Swami.
Sir, Rohit Swami sir is also not joined.
Okay, I am there also, no problem.
So are my slides visible?
Yes, sir. Yes, sir. So you can begin.
So welcome again. So I'm going to basically have a small panel discussion on the biomarker testing in CRC. So who all has joined for this?
I think only Jitendra got stuck, I think. I am in the place of Rohit there. Rajit is also there, I think.
Okay, we'll start.
Yashwant sir is also there, sir.
Yashwant, Rajit.
And Dr. Rakesh Sharma is also.
Okay.
So we'll start. So basically, we're talking about the CRC. So we all know that CRC treating a metastatic colorectal cancer patient, we need biomarker testing. So now it has been recommended in ESMO guidelines and everything that biomarkers are recommended upfront, and we have to do, ultimately down the line also it helps us to defining what kind of treatment we are giving. As we are getting more and more markers with us, we are getting more and more options with us, and guidelines and updating based on whatever kind of new markers we are getting and more drugs we are getting for this. So CRC is sort of like a personalized treatment based on the biomarkers and everything, what kind of treatment we start for the patients. So it's sort of, a case, not a true case, a 41-year-old patient.
हाँ जितेंद्र, अरे पैनल तो ज्वाइन कर ले यार, तेरी टॉक इसके बाद ले लेना फिर भले ज्वाइन कर ले प्लीज.
So basically diagnosed in June 2020, presented with a right abdominal pain, with jaundice, dark urine, pale stools, had anorexia, weight loss and fever, At referral, had a suspected of liver mass. MRI was done, which showed multiple liver mets were there. Metastatic nodes at porta hepatis were seen, and they were, compressing the common hepatic duct, causing sort of the patient presenting like a jaundice or a liver lesion. A PET scan was done, which showed a malignant process involving the sigmoid colon, along with multiple regional pelvic nodes. A small right lung nodule was seen, and extensive liver involvement was seen. A colonoscopy showed similar thing, 20 centimeter lesion, sigmoid colon's mass was seen. Biopsy shows a moderately differentiated adenocarcinoma. NRAS KRAS mutation testing was sent. Patient was, managed symptomatically. Bilirubin dropped initially from 18 to 5.3. Came in June 2020. So basically a newly diagnosed left-sided colon cancer with extensive liver metastasis and lung nodule at presentation.
Dr.
And-
Ankur, Dr. Jitendra has also joined, just for information. Okay.
So at this point, I'll ask what else now we should be able to do. What we should do for a patient who presents like this initial presentation, a liver metastatic patient with such kind of bilirubin, and what all at that time KRAS NRAS was sent. So what will you do at this time? We'll start from Dr. Jitendra. So what would you do? What else would you do for this patient before starting any further treatment?
So MSI not done earlier as I have joined late. First
Only KRAS NRAS has been done, and those are negative.
So an MSI by IHC or maybe an NGS full panel complete genomic profile. So that will help us. I don't know the age of the patient since I joined late.
40-year-old male.
So we have a young male. So probably we'll send NGS and MSI.
So the patient had a bilirubin, so it dropped to 5.3. So anything else would you like to do for that? It is basically because of what
that purpose is that it is an obstructive component it has, then we should offer a PTBD or stenting, and then we will see how we can give full dose chemo.
As patient had basically porta hepatis node, which is sort of compression on this. So again, you're right that nowadays we have 2 markers more, which we can at least NGS might gives us more marker, though we don't might have the therapy, but still it gives us more markers for patients, especially who doesn't have any kind of mutations we see normally KRAS NRAS. So nowadays we ideally should do MSI because we have targeted treatment for that. NGS might give us some less common markers like HER2 and TRK and all those, or BRAF. So basically a newly diagnosed patient. So he was started on initially FOLFOX, and then the NRAS KRAS result came out to be negative. Patient was started on cetuximab from second cycle along with FOLFOX. So if we look at this, basically this is a 2020 ESMO guidelines, which shows what all kind of treatment we can do for these patients. For frail patients, either just fluoropyrimidine plus bevacizumab, because the basic backbone is fluoropyrimidines. For patient with the RAS wild type, we can end anti-EGFR. If patient is RAS wild by ERA wild type, for left colon, we usually prefer anti-EGFR. For right side, we prefer bevacizumab. And eventually down the line using other drugs, which we are not using in the upfront setting. So how would you have treated now these patients? So I'll ask Dr. Rajit Channa, but how would you have treated, if you would have treated differently, what else would you have done for this patient?
So if obstructive jaundice, I would probably get the biliary drainage first. I'm not sure
biliary
whether
drainage was done. Bilirubin came down to 5 from 18, 19 something.
So what was this patient treated with initially? Cetuximab and chemotherapy.
Plus cetuximab.
I would treat it this patient same. I would treat it with this combination and chemo and targeted therapy.
So would you prefer? Do you have any preference whether to give 5-FU infusional or to use capecitabine?
So see, in terms of efficacy, there is not much of a difference between these two molecules. Capecitabine is probably more nephrotoxic. 5-FU is more safe. So if the patient has borderline PS, then I would have preferred 5-FU leucovorin infusion. If the patient was fit, then I I don't mind giving any of the two combination, but the problem with giving capecitabine is that the data of cetuximab, panitumumab is the dosages is mostly for a 2 weekly regimen. So that would have been a difficult thing to manage. Otherwise, I'm okay with both Folfox or Kipox, but would prefer Folfox because the targeted therapy can also be given in this 2 weekly schedule.
So would you use cetuximab only, or would you prefer to use bevacizumab? Any preference? Do you want to change?
So this was sigmoid colon and wild type, right?
Yes.
I would panitumumab or cetuximab, both are equal.
Yeah.
Although nowadays after paradigm study more data for panitumumab, but if this patient was already on cetuximab, I would have continued with cetuximab.
I totally agree. Panitumab has recently shown a much more better, but we still have, I think, enough evidence with cetuximab as well to use in the CRC setting for the wild type patients with paradigm. Yes, now we know that even for the right-sided patient who are sort of multi-gene negative, again, these patients benefit from adding the EGFR inhibitors. So patient received 4 cycles of Folfox plus rituximab, and then imaging was done, and it showed almost complete metabolic resolution. There was significant response. Liver disease was almost we were not able to see. Lung nodule was metabolic resolved. Nodes were almost metabolic resolved. Thickening was very, very much reduced. So patient had a dramatic response. But a liver MRI or similar liver MRI showed the same thing. So patient continued on that same 4 more cycles. Total 8 cycles were completed. Rituximab was continued. Again, then the liver MRI showed the liver metastatic lesion appears smaller, that it has stopped in growing, and there are no new lesions. PET scan showed more or less the same thing, but there was some hypermetabolic activity in the segment 6 along the drainage tube, which might be due to PTVD, so it was considered inflammatory. So patient had received 8 cycles and is continuing to respond. So at this point, I will ask patient, again, we'll discuss this after. So patient, same thing, continued on, completed 12 cycles. So 6 months of treatment, we usually give with Folfox. MRI and everything showed that patient is continuing to respond to this 12 months of, this 6 months of treatment along with cetuximab. So now, how would you like to do further? What would you like to do? Switch to maintenance or to give something else? So, Dr. Rohit Swami, would you like to take this question?
Rohit is not there.
Dr. Rakesh Sharma.
Sir, I would like to shift the patient on maintenance, although there is an option of continuation of Folfox with cetuximab till there is no toxicity or toxicity is easily manageable. But otherwise, we can give break to the patient from chemotherapy.
So what would you give in maintenance? Just cetuximab? Or combine with capecitabine?
Cetuximab plus 5-FU.
So would you prefer to give?
No, 5-FU or either capecitabine.
So in continuation, in maintenance setting, would you prefer to give a infusion of 5-FU or you prefer to give capecitabine?
Sir, because it is patient friendly, but 5-FU is also an option. So I think I will choose capecitabine with cetuximab.
So would there be an option of just containing cetuximab and giving a complete break, just stop chemotherapy at all and just continue cetuximab and to restart when if we see some progression, whether that might be an option?
So there are some evolving data regarding that, but I think age-old dictum is that you have to combine targeted therapy with 5-FU or capecitabine for a better overall survival. Although there is some data evolving early tumor shrinkage, which can guide to cetuximab only maintenance, but given the young age of the patient, I will stick to the combination.
Yeah, definitely. We have better data we're using because 5-FU has been the backbone of all the trials and all the studies of maintenance.
Yeah.
And has clearly shown PFS, good PFS, and some OS benefit as well. And I think cetuximab has shown a survival benefit in the first line setting. So ideally, yes, we will continue cetuximab along with 5-FU or capecitabine just for the ease of convenience for the patient we tolerates.
Yes.
So same thing as I already told you that regarding We use for patient first line maintenance therapy. Uh, what additional we can do? What more can we do? Patient progresses on irinotecan based therapy. We give oxaliplatin based therapy. Patient progresses on oxaliplatin. We can give irinotecan. We can change the when the patient progresses, whether we can switch to the different targeted therapy, switch from anti-EGFR to bevacizumab, or vice versa, depending on whatever kind of therapy which we give in the upfront setting. So if you look at this study, this phase 3 study for patients, RAS wild type, they were randomized by adding cetuximab with FOLFIRI or just cetuximab FOLFIRI plus the cetuximab monotherapy or continuing both the drugs. And we can see for patients who are given cetuximab monotherapy maintenance or cetuximab FOLFIRI, there was not any major difference in whether we give PFS. So there was not that much of benefit of continuing chemotherapy along with giving a FOLFIRI chemotherapy along with this. Patients, yes, benefited with cetuximab monotherapy, more or less similar, and were able to tolerate it better. So they might be able to take it for a longer time compared to just giving us chemotherapy or all these things. So can ETS be considered as surrogate marker? I don't know what ETS is. I'm not able to understand this.
You have to tell Ankur, I ask how he will answer, man.
Early, sir, it is early tumor shrinkage.
Oh, you think for me.
So my take is whatever therapy has the best response, we should continue the same. Second thing, we have to keep quality of life into mind regarding the maintenance. So if patient has intolerance to any of the agent, we should try avoiding that agent in maintenance. Otherwise, we will lose the purpose of quality of life. So whatever is there, we should maintain the quality of life. As well as we all know that data of chemotherapy as well as targeted therapy maintenance, that majority drugs were able to give only PFS. There were very few trial with an overall survival advantage. So ultimately, the main aim here is the quality of life.
Yeah, very true. Because I think there are very few studies, 2 or 3 studies, which ultimately showed OS benefit. Majority of the study were not able to show the OS benefit.
And those two were very marginal.
Very few. I think
Means
hardly 3 or 4
we
were
keep
different.
digging the data. If we go and dig solar field, we will get some gold. But what is the cost of it? That we have to keep in mind.
Definitely true, because we are giving cetuximab, which has some sort of toxicities. We have to give for 1 year, maybe more than that. So definitely, yes, patient will have a lot of toxicity. So we have to choose. Let's say patient develops toxicity, we continued the patient on capecitabine. Let's say patient was switched to capecitabine and cetuximab, and patient develops toxicity, say skin toxicity. So which drug will you stop? Then which drug to stop or to consider?
That's the question we should ask every time when we want to continue the
So what would be your preference to continue? What do you prefer more, capecitabine or cetuximab?
If it is only skin toxicity, which is grade 1, 2, I would probably continue targeted therapy because the major physiological reserve we deplete more is the bone marrow component. Bone marrow component cannot be replenished, and next line we have to give chemotherapy to add to biological. So probably I will try to avoid chemotherapy, but yes, if patient has grade 3, 4 generalized skin toxicity to cetuximab, probably I will give a break on cetuximab also. So we have to choose patient like that.
Jitendra, Ankur, what is the experience of me in head and neck cancer? That I am giving doxycycline from day one, and a patient, because it was mentioned in the step protocol of also, and
Yes,
of the TPX protocol. So patients are hardly any patients is having even hardly 1-2 patients are having grade 3 toxicity. Otherwise, rest are grade 1 or no skin toxicity after initiation of doxycycline without start from the day one of the cetuximab.
Yeah,
That is
totally agree,
my
because we can
experience.
start with
there
prophylactic.
are various studies for other EGFR inhibitor also, like minocycline. Even adding minocycline to gefitinib has shown PFS benefit in phase 2 studies. So we don't know how these drugs interact, but definitely toxicity has to be kept in mind.
Yeah, toxicity. it's more so sometimes with like a disregarded aspect. We don't look at the skin toxicity. So prophylactic measures helps a lot of patients. If we give
Yes, that
prophylactic,
has to
this
be practiced.
doxycycline and all those things helps a lot of the patients with the serious toxicity, and might help the patient to take the drug for a longer period of time rather than developing toxicity and stopping the drug and all those things.
Yes.
So further, what happened to the patient? Basically, patient, most of the disease was well controlled. Patient only had a liver only sort of disease. Everything was well controlled. So patient underwent a liver metastatectomy was done. Liver part of the liver was removed. The L procedure was done. Patient had some complications because of that. Recurrent episode of fever, basically because of a cholangitis. So did not complete the second part of the procedure. So basically liver lesion were removed. Eventually the primary was not removed for these patients. So then there appeared a new liver lesion after stopping the chemotherapy. The patient had a peripheral neuropathy, grade 3 neuropathy, probably the post side effect of the oxaliplatin which was used, and it developed after a treatment-free interval of around 3 to 4 months. So patient was planned for the same chemotherapy to be resumed because patient had a response. It was stopped because of the surgery and all those things. Patient was again restarted on Folpos plus rituximab, but the oxaliplatin was eventually omitted because of the neuropathy, and another 4 cycles were given to these patients. So how would you have treated this differently, Dr. Rakesh? Dr. Rakesh, Dr. Rajiv?
What was the time gap?
Around 4 months. Complete treatment free.
Probably I would have offered this patient Folferi and would change the cetuximab to anti-VEGF therapy.
The patient had a response, just it was stopped because of the surgery. So do you want to switch to switch? Yes, I agree. Irinotecan should be switched because the patient had a grade 3 neuropathy.
Response was after surgery, but still the gap is too less to again re-challenge with cetuximab. So there is data that you can re-challenge cetuximab in the third line setting. So I would have changed to VEGF, anti-VEGF, and would again reserve anti-EGFR for next line of therapy.
Would you like to do a marker testing at this time to see the
ideally, yes. There is data that you can do NGS in the blood and look for conversion of RAS mutation. But in all practical sense, I'm not doing it.
So let's say if the patient was tested and was still RAS wild type. So would you have continued cetuximab or still you want to switch to?
Yes. If this patient was still RAS wild type, then I would have offered panitumumab.
Otherwise, you would have switched to bevacizumab.
Yes.
Any other difference of opinion for this from any
See, here we have to ask ourselves two questions, two pertinent questions we have to ask. See, the primary was not removed, yes, right? Yes. So here liver had another disease after resection. So probably we all are dealing with the very worse biology disease. So we cannot re-challenge if probably the duration of response or this will be more than 6 months or probably a year. We should have challenged with the same therapy regimen because this is how they have defined in various modal. I mean, like in breast also AC Taxol. If you see the resistant mechanism, they say 12 months or for hormone also. So if you take that definition, probably we are very early and the disease biology is very bad. If there are a small node, after 1 year, probably you will challenge with the same. If the intent of surgery again is there, probably I will not add anti-VEGF, but I don't think the patient will be able to undergo surgery. So probably I will be concurrent with Folferi here. If surgery is not in question, probably anti-VEGF is the best option for this patient.
I totally agree. Patient progressed early, had a liver again disease. So yes, we right to switch from, even if we know the RAS status, we right to switch from to a different biological. Patient might have a better response to that. We don't know. So again, patient had a disease progression compared to previously. Patient didn't have any response. The previously seen metastatic lesion disease has increased. Again the bilirubin started to increase. It came to 9.3. Then the patient was switched to Folferi plus bevacizumab. Now the patient was switched. completed 5 cycles, and after 5 cycles, now the patient had a response.
So
Patient
we were
again.
right.
Yes, you are right. So patient completed 10 cycles of the same therapy. Now there was some signs of that there was some progressive signs. Early disease progression was noted after 10 cycles of this fall
So you were also right. So there are magical potions which we all have, and we don't know which potion suits to any patient. So this is how we medical oncologists. So now,
So I think basically here what comes the role of this genetic testing and all.
yes,
Yeah, broader the genetic testing we do, we might be able to better select the patient who will respond to what kind of therapy. Basically, whether he will respond to continue to respond to anti-EGFR or not. If we do a broader panel, just not doing KRAS, MRAS, BRAF will not help us much. Maybe doing a broader panel like seen in the paradigm might help us to better select this patient whether to continue cetuximab or switch to bevacizumab.
yes, maybe we need another magical thing to make a potion.
So now, what would be the third line treatment for this patient? Dr. Tarachan, you have any opinion regarding this?
Tara boss.
In third line, usually my choice is the regorafenib. Usually I use if the patient failed on FOLFOX cetuxi followed by FOLFIRI bev, then usually I go with the regorafenib for the third line.
So how's your experience using regorafenib? How many
मेरा
patients?
बहुत
Yeah,
खराब
160 is quite toxic, yes, but like in
Yes.
120 milligram is quite tolerable. So
Yeah.
I start with the 120 milligram, day 1 to day 21.
We have some data with 80 or 100 milligram. I think the patients are able to tolerate better rather than just
And
going.
aflibercept can be tried, but I think my preference is regorafenib.
And you think any role of S1 now to use in this later line of settings?
Yes.
S1 or now we have this tipracil.
Yeah, we can use. There is good data, but it's still because I have not used in many patients, and I'm using continuously regorafenib, so I'm more comfortable with regorafenib.
There might be your experience, but my experience, I think regorafenib is not tolerated at all,
Yes.
particularly in later lines of therapy. And S1, what I believe is very well tolerated drug, might be an option in later lines of therapy because we know that patient even if progresses on 5FA analogs still might respond to 5FA analogs. We have tipracil, TAS, and all these drugs are now approved, so might be an option for these patients. So anybody would like to re-challenge with again an anti-EGFR inhibitor in third line setting, or anything different they want to do? Any of the panelists, Dr. Rajiv?
Probably with the parenting data with an NGS showing still an wild type RAS family, probably I will incline because the patient is young. And
Yes.
regorafenib, I means two of my patients were means like they were not able to complete even 1 month with ATMG also. So means that's a nightmare. Every day, alternate day, I receive a call. So probably I will not until unless patient wants some oral medication. So probably I will fit patient. I will probably start anti-AGFR.
Yeah.
So regorafenib, the benefit is only of 1.4 months, and as you discussed that it is not a very safe drug. So I would probably give this patient, if there is no neuropathy, Capox with anti-EGFR re-challenge, or give option 4 based on the sunlight trial, bevacizumab plus TAS 102.
Yeah, if patient have a young patient, a good performance status still
Oh,
in the third
actually,
line
I have
setting.
not opted for option D because BEV patient has minimal 6-month PFS. So
there is
probably
data of
that
continuing
suggests
BEV
the
beyond
biology is
progression.
not on VEGF
So
dependent. That's why
there is-
that option probably will not help the patient.
So there is
Here
some
comes the
data
role
that
of
BEV can be continued
yes.
beyond progression. So in view of limited treatment options, this is one of the treatment options that can
Yes,
be.
it is one of the, but probably means
I think better than regorafenib any day.
means I cannot contradict
And
Dr. Tara.
what do you
He
think about
stay
the
in Jaipur
IROX?
only. He will
What
kill
do
me.
you think
I
about the
cannot
IROX?
contradict him.
Why do you think about the IROX?
न्यूरोपैथी
That
हो
is,
गया उसको
IROX.
न्यूरोपैथी है ना, बोला तो था उसको न्यूरोपैथी
अच्छा
हो गई।
न्यूरोपैथी है, चलो
सर
फिर तो नहीं
न्यूरोपैथी है
जाना।
सर। अरे
So-
तुम मरवाओगे यार सर, मेरे कॉलोनी में रहते, आ जाएंगे रात को।
चलो
So any option of
तुमको
using
दूर
just a
बैठे
single agent cetuximab, just a single agent monotherapy.
कैप्सिटमिन के साथ दे देंगे, मतलब we
हाँ,
have to single agent. There is data that it does have some response rate, but capcitabine we have not yet given. So at least some chemo component should be given if the patient is fit enough. And in colon cancer, we do re-challenge with the previous regimen that we have used, and we have not used capecitabine for this patient.
Yes.
Yeah, true. We can add if patient is,
We
patient is
can
able to tolerate, why not to add? Might
Yeah.
have some benefit for a few more months by adding the chemo plus targeted therapy. So regarding the challenge, I already told you liquid biopsy might help us to select the patients. We can, select to whether to do a EGFR re-challenge, because sometimes it happens that patient receiving cetuximab develops a secondary RAS mutation or secondary resistance mechanism, which makes them, resistant to EGFR inhibitors. Most common is the development of RAS mutation. And after some second line treatment, if we can do a liquid biopsy, that has been seen that around 20-30% of patients in whom that frequency of that VAF decreases of RAS mutation, these patients might again respond to a EGFR inhibitor. So making it again a valuable tool in the third line setting if patient is able to take treatment up to that third line setting. So the same thing as I already told you has been one of the recommendation, though not a strong recommendation, but yes, we can do a anti-EGFR challenge based on some phase 2 studies which we have. So patient was started on chemotherapy plus rituximab. So irinotecan was given single agent. Patient completed 7 cycles of again therapy and had some again a good clinical and radiological response with
दादा
irinotecan.
तुम बहुत लकी हो रहे हो.
पूरा पैनल डिस्कशन चलाना है, इसलिए पेशेंट भी लकी होना जरूरी है.
Agreed.
So some different questions. So in what do you consider that patients? Whom do you consider that patient? Let's say any patient, not this patient. Whom do you think that upfront a patient presents with a liver metastasis or any kind of metastasis? Which patient would you consider that yes, this patient can be considered a resectable patient, or this is purely unresectable patients? So what kind of how do you define those patients to define what kind of treatment will be given to these patients eventually? Dr. Jitendra.
देखो, ideally this should be a tumor board discussion. Surgeon should comment on it. But from my perspective, before referring a patient to surgery, I ask myself 3 questions: whether the disease is curable by the surgery itself, whether the surgeon can do the surgery in 1 step or 2 step, third, whether patient will be able to sustain that surgery. So if these 3 answers are yes, probably this patient is resectable. Otherwise, the patient is unresectable. Still, we will discuss it on tumor board, and then we will have a call.
So all metastasis will you consider whether they are not liver only, other metastasis also there, let's say oligo, lung mets or bone mets?
See, we have data of liver and lung. Bone, we don't have the data. Lung also some data is there. And few data of CRS plus HIPAC in peritoneal only disease. So, but I do believe that the colon who are metastatic to liver are different than peritoneum and lung. So probably liver will be the first. If patient is very young, responding good, probably in lung and peritoneum, I will suggest for surgery. Otherwise, I will probably initially give them chemotherapy and biology.
I agree. I think peritoneal patients do the worst. I think there have been studies with CRS, HIPAC, and none of them have shown a very good result. Even in the, I think, even
whatever you do, the target of QL is very, very hard to achieve.
Yeah, definitely. So what I have seen in practice is that peritoneal patients do the worst, and liver patients, yes, they do well compared to other malignancies in which we consider that disease going to liver, they do bad. But in CRC, maybe the patients with liver disease, as you are right, they might have some better biology because they comparatively do well. If we compare some other cancers where the disease goes to liver, we consider it as like a very poor marker. But
of the record, if you see all metastatic CRC patients, they all are liver. In all panel discussion across the last 4 years.
Dr. Ankur requests you to conclude the discussion in the next 2 minutes.
Because we know that because liver is the most common site of metastasis, and majority of studies, even we have phase 3 studies, all are of liver mets. We don't have any phase 3 study of any other mets other than liver, because it's the most common. You get the most patients of liver mets. That's the thing. So yes, I agree. They are different. Patient who does only have liver mets, yes, they are different with patients who present with different kind of peritoneal mets or lung mets or diffuse mets. They obviously do a lot worse than the patients who does only have liver mets, even if they are not resected. So my time has crossed, so I will cross the panel discussion, and thank you all my panelists for joining this. Thank you.
Thank you, Ankur, and thank you all the panelists for a wonderful discussion. Now, I invite Dr. Jitendra Pehlajani for the next talk, KRAS mutation in colorectal cancer.
So I would like to convey my sorry to the organizer, as I was in traffic, not able to reach home till now. So in car only. So we will see. As we all know, we were discussing everything about KRAS. So I thought, we know that now KRAS is coming up very well in lung. Means we know that it is an immune marker. So I thought let's think. Things differently and what has been done differently, rather than just burning with the old slide what fire says, what other trial says, that left versus right. Those all things probably we all know as a medical oncologist. So I will just touch up on the KRAS, how it's going to be changed in the near future, and then we will see it. And probably I would have taken this into the panel discussion, but my bad that it was not able to. Next slide, please. So this is the standard pathway. What we know that we have a EGFR receptor. There is a transmembrane receptor. There is KRAS protein which activated by triphosphorylation, and then we have RAF, PIC, MAC, and mTOR. So these survive the cell signal of survival and proliferation. So this is how the complex EGFR KRAS pathway seems. So that's how we see that if KRAS family is mutated, whether it is KRAS or BRAF, we don't have action of EGFR. Although there are trials going on the basis of precision medicine, where we target this BRAF, KRAS, and in combination with EGFR inhibitor, in phase 3 studies are going on in second line and third line, where we are doing it without chemotherapy. But let the data come, how the things pan out for us. And as we all know that medical oncology is an evolving field. Next slide, please. So this is what we can see, that in the colon cancer, almost 40% patients are KRAS mutated. In this, the codon 12 mutation are more common, which is 63.51. Out of this codon 12, 16 G12 do are more common. And as we can see that there is an continuous activation of KRAS when it is mutated, and which lead to cell survival and proliferation. So this is how these cells continuously mutate, and this is how they are being resistant. Next slide, please. So as we know that this KRAS is going to stay with us like HER2 is there now, because now the therapy is coming up. So probably now we cannot push it into a well that we don't know anything about KRAS, because probably it is not useful for the treatment. But as we know that in lung KRAS, anti-KRAS agents are being used. KRAS is used somewhere or other in predicting therapy to immune response. And we although know that KRAS is being used as a predictive marker in colon. So there are these paths. If you see the sensitivity, so next generation sequencing and Doppler digital PCR, means I have not done a droplet digital PCR till date, and COBAS. So probably COBAS and NGS is the way to go, rather than any other thing for whatever the lab says for a KRAS detection method. If you can do droplet digital PCR in a tier 1 city, probably that's the best. If somebody has the experience, they can share in the next one. Next slide, please. So we can see that codon 12, codon 13 are the most common mutation, and the prognosis depends on G12V versus G12C, and these are having a worse overall survival when compared to the unmutated patients. So if we can compare the efficacy of chemotherapy, which is FOLFOX, so these KRAS mutation, especially G12D, are predictor of inferior response to the chemotherapy and a higher risk of recurrence. So here we know that these patients who are KRAS mutated are having a worse overall survival, and they are probably resistant to chemotherapy in some subset of mutation. Next slide, please. So these are the robust predictor, as we all know that these are not inhibited by the EGFR inhibitors. And although there is a caveat that patient whose tumors harbor KRAS exon 2 mutation cannot derive benefit from EGFR treatment. So these are KRAS mutation works as a negative biomarker for EGFR mutation therapy. Next slide, please. Although we have some mutation like KRAS G13D, which can benefit from cetuximab. That's why probably the data is deviated. So we should dig deep in the data. And if you see after paradigm, probably NCCN, which used to suggest that left-sided wild type KRAS, probably that left-sided had been edited very wisely. And now it is wild type KRAS BRAF for any EGFR therapy. If you see the latest NCCN guideline. So probably now the sidedness again will fade off in the coming future, and probably now this will be like what we do EGFR and EGFR L cross in lung. That if these mutation are there, then probably we will not be able to do immunotherapy. Otherwise, we will be able to do. So similarly, if these mutation are there, only then we cannot do EGFR antagonist therapy. Next slide, please. So these are the trials which suggest us like KRAS inhibitor, SOS inhibitor, SH2 inhibitor, the RAF inhibitor, the ERK inhibitor. So these are various studies which are now in phase 1 or 2. And these studies suggest us that yes, KRAS is the next domain like we have in the lung sosartan and other agent which are being used in combination as well as alone. So there are trials which are going as a single agent. Next slide, please. So there are also combination trial with this KRAS inhibitors in combination with all these agents and with chemotherapy. So which will give us the data in coming future that whether KRAS has to be done as a negative predictor marker like HER2 we used to do earlier, but now HER2 is being taken as a possible target by which we can give a benefit to our patient. Next slide, please. So coming to the conclusion of this talk, that KRAS plays a critical role in the prognosis, diagnosis, and treatment. So like as we have seen that KRAS G-C type inhibitors have pushed research on targeting KRAS to new level. And one more thing that now we know that only only having a KRAS does preclude to EGFR mutant. Now the side effects probably doesn't work. And probably there are new arena for research for us. And we should see KRAS as a different different sequencing, and not all KRAS are the same. Thanks for the opportunity.
For a nice talk. And now this was the today's last talk today. And at the end, I would like to thank Dr. Asim Samar, who gave the way to start this session of today.
Sir, you are muted. Dr. Tarachan, sir, you are muted. Hello, sir. Sir, you can come again. You are muted, sir.
So now at the end, I would like to thank Dr. Asim Samar, who started this conference and gave the way in a wonderful direction. And then I thank Dr. Suruchi Agrawal, who enlightened us with the hot topic of the prostate cancer biomarker, which is the era of new generation, which is directing us for the future. And Dr. Ajay Singh, who spoke on the most controversial topic of neoadjuvant approach in high-risk prostate cancer, and make the clear line how to give or when to give or when not to use the neoadjuvant approach in prostate cancer. And we missed Dr. Devesh Goyal, who could not attend because of his illness today, but he made a wonderful presentation which I presented today on the targeting new targets and agents of upper GI cancer. Dr. Jagdeep Singh from Ludhiana, who gave a wonderful talk on HER2 pathway in upper GI tract, which is another target other than KRAS, BRAF, usually talk about those, and that is HER2 is also a very good marker and which improves the results in the colorectal or GI cancers. And Dr. Ankur Punia, who delivered a talk on Obdaita first line gastric cancer, which was the practice changing marker, and now we are waiting again another article since then and research. And he also moderated the case-based panel discussion on metastatic colorectal cancer. So I thank you, Dr. Ankur Punia. And I thank Dr. Rajit Chanana, who updated us in the management of first-line biliary tract cancer. After a long time, we could have seen the new drug in biliary tract cancer, which improved the survival. That is the most dreaded among the most dreaded malignancies. And Dr. Jitendra Pelayani on the KRAS spoke about the KRAS mutation and suggest the pathway how to manage these mutations in the colorectal cancer. And at the end, I would like to thank our pharma partners, Dr. Reddy Lab, DRL, AstraZeneca, Merck, Mankind, Super Specialty, Freshness, Kaiser, Avi, and Pfizer, and Zydus and Medgenome. And at the end, I would like to thank Horizon for the smooth smooth execution of today's meeting on the GI and prostate cancer. And at the end, I would like to say bye, and we'll meet tomorrow for the lung cancer session. That is going to be a wonderful discussion. There are all the panel, all the aspects we are touching tomorrow of the radiation, surgical, and medical oncology part and molecular oncology part of the lung cancer. So thank you.
Thank you, sir. Thank you, everyone, for joining. Thanks to my colleague Yashika and Gitika and the support team. I hope to meet you